My name is Lakshmi Yatham. I'm the president of the World Federation of Societies of Biological Psychiatry. I'm also the co-chair for the ACUMEN, an e-learning program on cognition. I'm very sorry to share the tragic news that Dr. Glenda McQueen, who participated as an expert in the module that you're about to view on management of cognitive impairment in bipolar II disorder, passed away in March 2020. Glenda was a wonderful colleague, an amazing mentor to countless students, a great friend, and a cherished leader. Her untimely death is a huge loss to Canadian psychiatry. We pray for her soul to rest in peace. Hi, I'm Lakshmi Yatham, co-chair of ACUMEN, the WFSPP e-learning program on cognition. Today, we're going to focus on management of cognitive dysfunction in bipolar patients. Some of the things that we're going to cover in this module include things like when a patient with the bipolar II disorder presents with cognitive dysfunction, what approach should a clinician take to address the cognitive impairment? We're also going to talk about non-pharmacological strategies as well as pharmacological strategies to address cognitive impairment in bipolar II patients. To talk to us about this particular topic, we have Dr. Glenda McQueen, who is a good friend and colleague from the University of Calgary. Glenda, it's so nice to have you in the program.
Thank you for having me.
Wonderful. So we know that people with bipolar disorder have cognitive impairments. The question is, are there specific domains that are affected in bipolar II patients?
The differences between patients with bipolar I and bipolar II appear to be largely of quantity or magnitude of severity rather than qualitative or specific domains. So patients with bipolar II have impairment in verbal memory, working memory, many executive functions, and often in selective attention. And those would overlap significantly with people who have bipolar I disorder, very similar domains.
So it's really the magnitude that's different rather than specificity in terms of the deficits.
Absolutely.
Okay. So in real-world clinical practice then, when a patient with a bipolar II walks in and complains of difficulty with remembering things or focusing, concentration, that kind of stuff. In that situation, what should a clinician do? What approach should he or she take to address the issue?
So a few things. If the patient is having significant mood symptoms, we would aim to treat those first, because we know that depression is associated with concentration and attention deficits. And if there are concentration and attention deficits, there will be problems with memory because the information is not being processed and laid down. We also know that when someone's hypomanic, they tend to be highly distractible and, again, not focused, not making good decisions, so executive functions are not optimal. And our first step would be to treat the episode if a patient is, in fact, in an episode at the time.
So, Glenda, let's say clinician changes medicines or uses non-pharmacological strategies to address mood symptoms, and those are now resolved. Patient is euthymic from a mood perspective, but continues to complain of cognitive difficulties. What do they do next?
So once a person is euthymic, that's a good time to rule out comorbidity, which is common in people with bipolar disorder. Attention deficit disorder, anxiety disorders, and substance use disorders all can have significant impact on cognition, and we need to identify those before we go any further.
So address the comorbidity, and let's just say comorbidity has been addressed, and they still have cognitive problems. Where do they go?
So our next step in assessing would be to consider whether any biochemical investigations are warranted, particularly if the cognitive complaints are of recent onset. But in any patient who is on lithium, for example, we would want to check thyroid function, because even subclinical thyroid dysfunction may have a negative impact on cognition. And low-grade lithium toxicity can also impair cognitive function, possibly most notably in older people. So we want to think about biochemical measurements and ruling out any abnormalities there.
So really looking at some physical or medical kinds of conditions that might be as a result of the side effects of medications or patients' physical illnesses that might contribute to these cognitive problems, and you're saying do the investigations to try and rule out those kinds of things. What about the side effects of medications themselves? I mean, are there psychotropic medications that have adverse cognitive effects?
Yes, certainly. And that's a good question and good point, because before we think about what to add on, we should always evaluate whether there is anything that we can take away. Patients who are being treated with benzodiazepines, for example, perhaps they were helpful in the mood episode, but now that they're euthymic, it might be possible to withdraw the benzodiazepines. That might improve cognitive function. Patients who may be using over-the-counter sleep aids with antihistaminergic properties, they may have negative impact on cognition. So we want a careful review of both what is prescribed and what substances are being taken that are not prescribed, and a good consideration to are there any things that we can eliminate.
Okay, well, that's a very good point, because sometimes we tend to focus on the medication that we prescribe, and you make a very good point about, don't forget to ask patients about over-the-counter medications as well, because these days, some of those medications, they can just buy it, and you may never find out from the patient unless you specifically ask for it, right? Okay. So let's again say that you've done all that stuff, and patient continues to complain of cognitive difficulties, and clinicians then sends the patient for neurocognitive testing. And the testing comes back and says, yeah, it's in the normal range. So what do you do? How does one explain that?
Yeah, that's always a worry for me. It can have material implications for the patient, because sometimes insurance companies will aim to use that as evidence that the cognitive complaints must not be real in some ways. But if we think about people these days who are either in work environments or in academic environments, we have an information-rich, knowledge-based economy. And often people who may well be within normal range on neuropsychological functioning have had a drop in their own performance, which may be significantly impairing for them, but not detected on a cross-sectional assessment.
That's again a very good point, because in one of the studies that we did in first episode manic patients, we did find that for a vast majority of these people, their cognitive functioning was within normal range, but as we investigated, we did find that their premorbid cognitive functioning was even higher. So it's really relativity, right? It's relative to their baseline rather than comparison to the age and sex-matched control or what's expected based on their age kind of thing.
Absolutely.
If the neurocognitive testing comes back as being normal, don't invalidate patients' complaints. You still need to take them seriously, and you need to try and do something about it.
Yes, and we've done a number of studies where we've taken people who have had standard neuropsychological assessment, have clearly fallen within the normal range. We've run them on computer-based cognitive neuroscience testing, And we can very frequently show that there are impairments in function compared to age and sex-based cohorts. One of the key factors that comes in there is that the tests we use are often more difficult, more challenging. And again, it comes back to if a task is very simple, if the environment in which a person is completing the task is quiet, controlled, there's no stress, they might be fine. But when we put them into different environments and really drive the system to see what it's capable of, there we see the problems emerge.
Now, what about the impact of these cognitive deficits in terms of school or work, those kinds of things? Because sometimes, clinicians come to see you and they look at your thymic, and, again, when you do some of the bedside cognitive kind of testing, it looks fine. But they say, I went back to school or work, and I'm just not functioning at the same level as I did before. What do you do with those kinds of situations?
So I think the first thing we do is validate that. And again, if we think about it, we've done a number of studies where we're able to vary the complexity of a task. And for most of our patients, when the task is easy, they will perform at or only minimally below healthy comparisons. But as the task is made more and more difficult, the cognitive demands are higher, we often see people, if you like, go over a performance cliff. And we believe that's what's happening when people are away from school or off work. They're often in very low stress, predictable environments. The cognitive demand is not high, and they may not appreciate that they even have cognitive deficits because they're not being assessed. When they go into a high demand, stressful environment where there may be multitasking, where they're feeling evaluated, where they are in fact being evaluated for their performance, then in those environments we see them really struggle.
It sounds like what you're saying, Glenda, is that when a patient with a bipolar 2 disorder presents with cognitive complaints, the first strategy is to take the systematic approach of eliminating various contributing factors to that cognitive dysfunction. And once you've done that, including peeling off some of the medications that might have adverse effects on cognitive functioning, if cognitive dysfunction still persists, would you then think about, let's say, psychological strategies?
Yes, absolutely. And we can divide those into 3 categories. One, lifestyle management, so substances, not necessarily medication, but thinking about use of alcohol, thinking about use of cannabis, other recreational substances. Strong advice that patients minimize the use of those. So substances, first, sleep. Second, people often have dysregulated sleep, and none of us perform cognitively better when we are chronically sleep deprived. So working on sleep for patients. Exercise, it's good for a whole host of reasons, but there is pretty good evidence that it might improve cognitive function. And then finally, diet. So several things that we would like our patients to optimize before we have to move on to a more intensive approach.
Okay, so lifestyle management is probably the initial step. And let's just say you've done that and cognitive dysfunction persists. Where do you go from there?
So then we would talk about a non-pharmacological targeted treatment strategy, like a cognitive remediation strategy. And there are a number of studies that have shown improvements in certain cognitive domains, some in general cognitive domains, and some in function after people undertake systematic cognitive retraining. One of the things I would say about that is I think we do need to be careful. There are some programs that are very good and that in a hierarchical way will work people through cognitive retraining strategies in a variety of cognitive domains. They're very good. Sometimes some cognitive remediation strategies may not be as systematic and may not be as helpful for patients.
So in terms of the evidence then for the benefit of the cognitive remediation, How strong would you say that is for people with the bipolar 2 disorder at this stage?
It's really indirect evidence where we are extrapolating from either major depression, bipolar 1, or in some instances from patients with psychotic disorders. So indirect evidence only.
So sounds like intuitively it makes sense, and it's worth trying because I suppose there are no negative consequences to trying cognitive remediation, are there?
Well, absolutely. We would believe that in most instances the risk or the risk of harm is going to be really minimal.
Now, you also mentioned in terms of the lifestyle changes, diet as well. So when you talk about diet, are we talking about a healthy diet or maybe dietary supplements, or what are we talking about?
Again, very little evidence specific for people with bipolar 2 disorder, but in general, an emerging body of evidence suggesting that certain diets, often a variant of the Mediterranean diet, may be helpful for cognitive function just generally and the preservation of cognitive function. Supplements, there's really very little evidence. Again, indirect, but even the quality of the indirect evidence is pretty low.
So, Glenda, let's say you've tried the lifestyle strategies and non-pharmacological strategies, and patient is continuing to have cognitive dysfunction. So at that stage, then, would you think about pharmacological strategies to address cognitive impairment?
Yes, absolutely. And many patients who have done everything right will still find that cognitive function is a major debilitating feature of the illness. So when we think about what to do pharmacologically, I tend to think of it in two ways. One, are there adjustments to the mood stabilizing medications that we can make that might improve cognitive function through procognitive effect? Or do we have to leave the mood stabilizers alone and add a different class of medication to target the cognitive function specifically?
Okay. So in contemporary clinical practice, I guess, there's obviously medications that are being investigated, I suppose, for improving cognitive functioning. But the medications that are at clinicians' disposal at this point in time, are there medications that might be better from cognitive perspective than the others?
As you know, having led one of the major sets of guidelines, several of the top medications recommended for bipolar 2 tend to be relatively pro-cognitive. So quetiapine, top of the list, lithium near the top of the list, lamotrigine also on the list. And those are good choices for people who have bipolar 2 as mood stabilizers. And they also, for others, back and forth in the literature, but the literature in general seems to suggest that they're unlikely to have a negative effect on cognition and may in some instances improve it. So if we have somebody with bipolar 2 who's not on one of those medications, and is really having cognitive difficulty, then we might have a conversation about can we switch them to something that still has very strong evidence for bipolar 2, but might also be able to target the cognitive function.
So Glenda, we talked about some of the medicines that are available in current clinical practice, but just looking at the future, if you were to speculate, what other classes of medicines might be potentially beneficial for treating cognitive impairment in people with bipolar 2 disorder?
So I'm very interested in your work with lurasidone in patients with bipolar 1. And as you know, it's not a medication that necessarily has clear indication at this point in time in patients with bipolar 2. But if those pro-cognitive effects are maintained and we get some more data, I think it will be a medication that's going to be worth considering in bipolar 2 for cognition, and also because it's unlikely that it would destabilize the underlying illness. There are a number of other medications. Pramipexole has some data from mixed trials. It's minimal, but shows some promise. There's been some work with intranasal insulin that shows some promise. There has been work with the acetylcholinesterase inhibitors, such as galantamine and donepezil. We did a small trial with galantamine a number of years ago in patients with unipolar disorder, and it was randomized, double-blind, so patients didn't know what they were taking, we were able to demonstrate small benefits in measurable tests of cognitive function. But the interesting thing for us was that almost every patient who was on galantamine elected to stay on galantamine post-trial. So that was provocative for us because even though the measurable differences were small, patients really felt they were appreciating some change. So I think there's a host of medications that don't currently have clear role in the treatment of bipolar II, but may one day be selected for their procognitive effect.
Okay, well, that's very exciting. So we talked about lots of issues pertaining to cognitive dysfunction bipolar II patients. I wonder for clinicians whether you can give some key take-home messages.
So a few things I will always try to keep in mind. The one is to approach this issue systematically, ruling out all the other things that can have a negative impact on cognition and really aiming to streamline and optimize what the patient is taking, both pharmacologically and non-pharmacologically. So first step for me, ruling out any underlying medical cause, kind of important second step. Optimizing lifestyle, because chronic substance use, chronically poor sleep, chronically poor diet, no exercise, those things are just not going to be good for brain health over the long term. And then at a later stage, thinking about pharmacological options and thinking about both what can we optimize as part of the mood stabilization component, and then are there agents that we might add in for their procognitive benefits, and aiming to choose ones that we think have very little risk of destabilizing the underlying illness. So that systematic approach for all patients is what I aim for.
That's wonderful. Thank you so much, Glenda, for taking the time to participate in this program.
Thank you.